We're fortunate to have tonight Dr. Leslie Montgomery, and in turn, Einstein and Montefiore are fortunate to have recruited Dr. Montgomery as Chief of Breast Surgery in our Department of Surgery, both at Einstein and the Montefiore Einstein Center for Cancer Care. She comes to us from Memorial Sloan Kettering, where not only a terrific surgeon, but someone who also applies research methods to really understand how to better take care of patients. Issues that she's addressed include questions of sentinel node biopsy, and I'm sure she'll share some of that as she discusses, okay, you've had the mammogram, there's unfortunately some trouble there. What are the surgical options? What about lumpectomy, mastectomy, reconstruction, etc.? So Dr. Montgomery.
Today I'm going to talk about advances in what I consider to be local control. As the surgeon, my primary job is local control of the cancer itself, as well as accurate staging, which allows Dr. Sperano and his team to effectively evaluate the patient with respect to prognosis, risk of recurrence, and a framework with respect to chemotherapy or the need for chemotherapy. But my primary job is local control, which often in and of itself affects the cure. So let's talk about some of the advances that have happened. And I really sort of decided to start with the time that I started training, even as a general surgery resident, how things were done when I first started and how things are done now, to give you a sense of how far we have come. Just to give, for those of you who haven't seen it, this is our brand spanking new not breast cancer center, I wish, cancer center over at the Montefiore Einstein Center for Cancer Care, where in this place we have really perfected the concept of multidisciplinary care. Again, when I first started, there was the surgeons, and we operate on the patient, and then the medical oncologist got involved, the radiotherapist got involved, and we didn't do a lot of talking with each other. There was a defined order by which a breast cancer patient went through her treatment, and there wasn't necessarily that much communication during the course of treatment. Here at cancer centers and throughout the country, more and more often cancer is approached in a multidisciplinary fashion where everybody who's involved in the patient's care, from soup to nuts, starts out her treatment and comes up with a different order that may be tailored to a patient's specific situation. At the Cancer Center, and particularly with the breast service, we're not just focused on cancer. In addition to the different types of breast cancer, ductal, lobular, DCIS, we also see patients with abnormal breast imaging even before they have a cancer diagnosis, or if there was an abnormal a biopsy that gave an atypical or abnormal results or discordant result from the radiologist. In addition, we also follow our ladies who are very high risk, although they may not have developed breast cancer. They need to be followed closely by both the radiologist and a breast surgeon, breast specialist for early detection. So as you know, unfortunately, breast cancer is the second leading cause of death of American women. And in 2009, approximately 40,000 women succumbed to this disease. It is the #1 cancer in American women. And if all of us expect to develop some sort of cancer, obviously mostly skin cancers, 1 in 3 of us will develop some sort of malignancy during the course of our life. You can see that breast is #1 with respect to women. 1 in 8 women will develop actual breast cancer, whether it's invasive lobular, invasive ductal, or DCIS. So this is clearly an enormous problem in this country, and something that we need to address. Let's start out talking about the diagnosis, and I'm sort of picking up where Dr. David left off. A woman who has an abnormal imaging of some sort, or even earlier on when I first started training, when routine screening imaging was not necessarily as prevalent as it is now, a woman with an abnormal physical finding. And it used to be that that person went to the operating room to have this surgically removed, and be it benign or malignant, it was out of her. And for the vast majority of women, this was a benign diagnosis. Now, happily, we like to focus on what we consider to be core needle biopsies for diagnosis, keeping a person out of the operating room and doing an office procedure where a core needle is placed into whatever is the abnormality. If it's a palpable lesion, then I can do this for the patient in my office. Otherwise, if it's an ultrasound lesion, a mammogram lesion, or even an MRI lesion, the radiologist can take care of this within their radiology suite. The data shows that if we know, number one, that most imaging proves to be benign, especially in the world of calcifications, and therefore keeping a lady out of the operating room for an unnecessary surgery is of significant value. Also, the data shows that if a surgeon knows going into that initial procedure that the patient has a cancer diagnosis, I'm much less likely to have positive margins. I'm much less likely to require a second operation to ultimately achieve a definitive cure. So starting out, I think one of the major advances, even before they get to me, is this concept of the percutaneous biopsy, not the excisional biopsy, to achieve a diagnosis. So by the time she comes to me, we all know basically what we're dealing with. And this is just some schematics of these kinds of pictures. This is a rather dramatic tumor, but if I can feel this in the operating room, in the office, a percutaneous core biopsy. This needle is something about the diameter of a strand of spaghetti, for instance. This can take a piece of tissue to give me a definitive diagnosis. It can also give me the markers that may be used by Dr. Sperano for subsequent treatments, even if necessary before surgery. If the lesion is only seen by ultrasound or best seen by ultrasound, this is clearly the easiest way for an image-guided biopsy, so that the radiologist can achieve a biopsy that way. Or if necessary, calcifications can be biopsied using the mammogram machine. The point is that she's not in the operating room. She's not undergoing any sort of systemic anesthetic other than the local anesthetic to achieve a diagnosis, be it benign or malignant. So now we have achieved a diagnosis, and she comes to me. And there are two parts to what I'm supposed to do. I am supposed to control the cancer in her breast, and I'm also supposed to figure out whether the cancer has moved from her breast to the axillary lymph nodes or the lymph nodes in the armpit, which is the first place that in general that breast cancer likes to spread. And if so, that is something that I can surgically remove from the patient. And my job is to ultimately remove as much gross disease from the patient as possible. With respect to the treatment options, as you are all aware, there are basically two: breast conservation therapy, or the lumpectomy, or the mastectomy. And as I started training, the mastectomy was still being done fairly routinely. At this point, I'd say it's safe to say that most patients, particularly in the Northeast, who have a great deal of screening, probably 80% of patients undergo breast conservation therapy, and perhaps 20% undergo mastectomy. It depends significantly with respect to socioeconomic status and regionally across the United States. But you can see here that there are many options even within these two general categories. In general, when we offer patients breast conservation therapy, as you know, it is a lumpectomy, always coupled with radiation therapy. Both of these modalities have undergone significant changes over the past 10 to 15 years, and I'll talk about those in a second. With respect to the mastectomy, it used to be that many women who presented with invasive breast cancer were looking at a modified radical mastectomy: removal of the breast, removal of the nipple, and removal of those lymph nodes, and that's called the modified radical. This is now becoming less and less necessary as we move towards a total mastectomy coupled with a sentinel lymph node biopsy, moving even to skin-sparing mastectomy, whereby simply the nipple areolar complexes is removed as we start approaching sort of a standard of care where we do immediate breast reconstruction. And now I think the most interesting aspect of what we do at this point is this concept of nipple-sparing mastectomy. It has always been a significant concern, as we know that the milk ducts go through the nipple, that we would be leaving breast tissue behind if we were to spare the nipple. And so classically, the nipple is always gone. However, the reality of the situation is not a lot of breast cancers happen actually within that nipple. And more people are considering the concept of nipple-sparing mastectomy. And this is a buzzword that you'll hear a lot about. However, one has to understand that while this is a great concept, if one is going to have a reconstruction and a nipple-sparing mastectomy, the nipple needs to be in the proper place for the plastic surgeon. So not every woman, even though it may be oncologically safe, it may not make cosmetic sense to do this. And so it is something that, while more and more people are offering this option to patients, from an oncologic standpoint, from a plastic standpoint, it may not be in the patient's best interest, and it is really taken on a case-by-case basis. So let's talk about the lumpectomy. And if you envision, now that you have x-ray vision, and you're able to go through her skin, and these are the axillary lymph nodes in general, all clumped together. You really can't tell who's first in line that might receive the cancer. You obviously can't see any of these green lymphatics. And so you can't really tell who's first in line to receive the cancer, nor can you tell whether, usually from node to node, if they have cancer in them, whether or not they're involved with cancer. The lumpectomy itself is not only removal of the tumor, but also wide margins. And this is something that I think is very important to discuss, this concept of having a surgeon who, a dedicated breast surgeon or a person who does this a lot, is much more likely to get this in the dead center of the lumpectomy cavity and not be off-center and not take an unnecessary large amount of tissue to get out that tumor. In addition, having pathologists who can very carefully look at these margins and assess what is positive and what is negative is very important, as we know that people who have closer positive margins have a significantly higher likelihood of recurrence as opposed to people who have negative margins. So the lumpectomy itself requires practice, and the pathologist who is reading this lumpectomy or analyzing the margins in particular is very, very important. Ultimately, what you hope to have is a small cut in the lines of skin tension that heals in a straight line. And so we're very careful about our lines of skin tension so that we don't end up with a widened scar. We also try to employ what we call oncoplastic techniques, whereby now that there's this space where the lumpectomy used to, where this cancerous tissue used to be, we like to mobilize some of these, the surrounding breast tissue to help maintain the appropriate contour of the breast. So the ultimate goal in a lumpectomy is not only to achieve a cure and minimize recurrence, but also to leave the patient with the best possible looking breast as possible. The last aspect of breast conservation, as you're all aware, hand in glove, you get a lumpectomy, you need, for the most part, you need to have radiotherapy. And for those of us who, for those people who, gone through this, you know that the standard radiotherapy is Monday through Friday, 5 days a week for 4 to 5 weeks. And that's sort of a mantra that this occurs over a period of time. Why is that? It's really because, it's not because the breast tissue itself can't tolerate a big dose of radiation. It's because the skin overlying the breast is very sensitive to radiation. That's why we get sunburns. And that this skin can only take a small dose every day. And that's why this has to be spread out over a period of time. And so classically, it's getting the entire breast, small doses that's spread out over a 4 to 5 week period of time. What we recognized over the last 10, 15 years is that most breast cancers that reoccur in a person's breast do not happen in a random location. They tend to happen at the lumpectomy bed. So why do we radiate the entire breast when the danger area is actually where that lumpectomy is. And so I think one of the significant advances that we're looking at is this concept of partial breast radiation, that we can do two things. Number one, we can focus our radiation exactly in the lumpectomy bed itself, and that we can bypass the rate limiting factor, which is the skin. And how do we do that? Because what we can offer people nowadays is radiation that is given twice a day for 5 days. And so in 1 week, a person can achieve the same dose of radiation to her underlying breast tissue as it used to take 4 to 5 weeks. The way this works is that there is this catheter, believe it or not, that is inserted. Once the margins are deemed to be benign, this catheter is inserted in an office procedure into the lumpectomy cavity. And this is the way that the radiation is going to be inserted on a daily basis. So thus you can see the radiation misses the skin entirely. You're no longer blasting radiation from outside the body, you're actually delivering it through these catheters inside the body. And that, if you can see, this is this balloon that gets filled up, and then these radiation seeds would come in. And the physicists can actually very carefully tailor the amount of radiation so that the most amount of radiation is given to the biopsy cavity. They can minimize the radiation to the underlying heart and lung. They can minimize the radiation to the overlying skin, and very carefully modulate what is getting radiated and what is not. So a much more focused approach than this whole breast sort of shotgun approach that we used to do. This is not an appropriate option for everybody, but the point is that it is an option for many people, and as we get better at it, the indications will probably expand. And I really believe that this concept of partial breast radiotherapy is going to be one of the directions that we go in the future with respect to breast conservation. So let's move away from breast conservation and talk about, in the situation where a woman either requires or chooses to have a mastectomy. And as you all know, that involves, in general, removal of the nipple areolar complex, most of the skin, and the breast mound itself. And that's the classic total mastectomy. Now, nowadays, what we like to do is, as I said, skin-sparing mastectomies. This can be done where the entire breast mound can be removed through incisions around the areola. And nipple-sparing mastectomy is where you will make an incision down here and remove the entire breast and leave the nipple behind in various incisions that actually leave the nipple in place. So I think the concept is that as long as the cancer is not in the skin does not need to go. Thus, leaving the skin behind allows an empty pocket, if you will, to be filled with immediate breast reconstruction. And I think it's very important, and another significant advance is this concept that it's very helpful psychologically, and there is absolutely no harm in doing immediate breast reconstruction, so that the mastectomy, I finish my mastectomy, I walk out of the room, the plastic surgeon passes me in the doorway and starts that immediate breast reconstruction right then and there. Yes, the patient doesn't wake up with a perfect breast, and it is a work in progress, but it's forward progress. And this is, I think, another advance, not assuming or being concerned that reconstruction at all ever limits a person with respect to the oncologic cure and the progress towards treatment. So with respect to these, with respect to these types of reconstruction, as you're probably all aware, the tissue expander, where the pectoralis major muscle is elevated, this expandable bag of salt water, if you will, is placed underneath the muscle like a muscle halter top, if you will, and then this gets pumped up over a period of time until it matches the other side. Keep in mind, it is a federal law that reconstruction after mastectomy is paid for by insurance. In fact, any procedure that has to happen on the contralateral breast, symmetry, making you bigger, making you smaller, whatever it takes to match the cancer side, is also paid for by, paid for by insurance. And that's something that is often a deterrent for patients, because I think that cosmetic surgery is usually not paid for by insurance. This is an exception to that rule, and it's important that people know that. Other options, as you know, is the tram reconstruction, moving muscle and fat from the abdomen, what we call the blue plate special, because you get a tummy tuck and you get a new breast, so we like that. No, we can't really do we don't do anything else with the face, but this is as much we can give you here. Moving muscle and fat around, making a new breast mound, but even taking it farther, because you can imagine losing this rectus muscle does change a woman's ability to do a sit-up, does increase her risk of hernias. So another recent advance that has come up that our plastic surgeons are capable of doing is leaving the muscle intact, taking the blood vessels that penetrate that muscle and taking the overlying fat and skin to make that reconstruction, which is known as a deep flap. Thus leaving the abdominal wall where it belongs and taking that extra fat and skin, which none of us particularly like anyway, and putting it up and making a new breast reconstruction. I think it's important that you all recognize that in September of 2010, the New York State Legislature passed a law that was authored actually by Dr. Evan Garfein, who's one of our plastic surgeons here at Montefiore. He's been here for about 2 years now, and he was very surprised at how many women came to him having had a mastectomy years ago and who were never informed that reconstruction was an option, either at the time of the procedure or subsequently. And so he felt so strongly about this issue that he actually, and he knows nothing about law or the legislature, but he actually has this now signed into law as of September, that it is now mandatory in the state of New York that every woman who is recommended to undergo a mastectomy be advised at the time of that recommendation that reconstruction is an option, either immediately or even in a delayed fashion. So I think that's something very important that Evan has put forward, because I don't think any woman should not understand that that is an option. She may choose to not have a reconstruction, but it should be her choice. It shouldn't be just because she wasn't told of the options. With respect, I'll finish up here quickly, with respect to what I think is the most important aspect of a staging for the axillary lymph nodes and control of the disease. You know, when I started, every woman who had invasive breast cancer had to have an axillary lymph node dissection. You had to know whether there's cancer in those lymph nodes. It would tell her about her prognosis. It would tell Dr. Sperano at the time whether or not chemotherapy was necessary or not. For the vast majority of women with early stage cancer, this surgery showed us a whole bunch of negative lymph nodes. And it left women with the sequelae of having those lymph nodes taken out, including lymphedema. But this had to be done because we didn't know how to figure out who would be the first lymph nodes, how to test whether we couldn't just berry pick and take out a couple. They all had to be taken out. Now we do what's called a sentinel lymph node mapping, and this is an extremely important advance in the world of breast surgery. In this way, we can reconstruct the pathway that a cancer might have used to get to the lymph nodes, which can identify the very first lymph node that this particular cancer might spread to. We do this by injecting a tiny drop of blue dye and radioactivity into the tissue around the tumor, which then gets sucked up by the same lymphatic channels that the cancer exploits to move to and mark the sentinel lymph node. It moves to the sentinel lymph node, but gets stuck in the first lymph node. In this schematic, it's one lymph node. In general, it can be anywhere from 2 to 3. Everybody's different. The average number is about 3. But the point is, as opposed to this whole sort of cluster of grapes, you now have a couple of lymph nodes that are blue and radioactive. These are my most likely suspect. These are the places that this particular cancer would have gone to first. And what we do is these lymph nodes are removed and they are looked at right then and there in the operating room. And if they are clean, then we believe that that reflects the rest of all these lymph nodes, and we do not have to take the rest of them. It answers the question that this is a node-negative lady and that nothing further has to happen with the axilla, and we do not have to worry about lymphedema. If the lymph node is positive, then we know from data that we have about a 60% chance that there'll be other levels of lymph nodes that have cancer. And with that level of risk, we do, in general, a lymph node dissection to, again, cure her of this disease. But to to identify the ladies who are node negative saves them from that axial lymph node dissection. And I think this is an extremely important advance in the world of breast surgery, probably one of the most important. So in summary, what we are trying to do is minimize our impact. The surgery is we are trying to minimize our impact. Our primary objective, of course, is to maximize local control and cure. But rather than going through a radical mastectomy, the deforming radical mastectomy, the modified radical mastectomy, we are shrinking what it is that we need to do as we learn more and more about this disease. That we have minimally invasive diagnostic techniques. We now have minimally invasive surgery and radiotherapy, so that with dedicated breast surgeons, dedicated breast pathologists, and these options regarding whole and partial breast radiotherapy, we can maximize our local control. But at the same time, we are minimizing, since most women are going to survive, most women are going to live long, healthy lives, we want to minimize the risk of lymphedema. We want to minimize the sequelae and the cosmetic deformity, whether it's a lumpectomy or a mastectomy, that we impart on a patient. And this is just our breast team, whether it's a plastic surgeon, radiologist, medical oncologist, the nurse practitioners, the radiotherapists, the surgeons, we're all there. And we now do a lot more talking to each other as we try to tailor each and every treatment to the patient. Thank you.